Welcome to the Urban Health Collaborative's Invited Speakers Series. My name is Jim Bueller. I'm a faculty member in the Department of Health Management and Policy, and I'm also an affiliate of the Urban Health Collaborative. And I have the tremendous pleasure of introducing our speaker today, Dr. Jeffrey Hom. Dr. Hom is a policy advisor to the Health Commissioner for the Philadelphia Department of Public Health, where his present focus is on the problem of substance abuse or substance use, which is the focus of his topic today. Dr. Hom has had an amazing and fascinating career trajectory on his pathway to his current position at the Health Department. He's worked in healthcare and public health in San Francisco, Boston, Shiprock, New Mexico, which is Navajo land, as well as internationally in Lesotho and Cambodia. For his efforts, he's been selected and honored as a Zuckerman Fellow at Harvard Center for Public Health Leadership. He's a Fellow of the College of Physicians of Philadelphia and a Presidential Leadership Scholar. Dr. Hom received his MD degree from the Harvard Medical School and his MPH degree from the Harvard School of Public Health. He completed residency in primary care internal medicine at the University of California at San Francisco. He's board certified in internal medicine, and he remains clinically active and provides care to patients at the VA Medical Center here in Philadelphia. Prior to joining the Health Department, Dr. Hom was a fellow in the RWJ Foundation's Clinical Scholars Program at the University of Pennsylvania, where he obtained his Master's of Science in Health Policy Research. We're very, very lucky to have him with us today, and we're looking forward to your presentation on opioids and substance use in Philadelphia.
Thank you, Dr. Bueller, for that introduction, and thank you to the Urban Health Collaborative for the chance to be here today and to engage with all of you. It's great to be here. I've had a good morning already, and I'm very inspired by everyone that I've met. And I appreciate the chance really to share with you about really what is one of the greatest public health crises that's facing our city today. So here's a little bit about what I'll be sharing today. Talking about the magnitude of the opioid crisis, how we got here, what the city is doing, some new challenges and opportunities that have arisen during this crisis, and then really end with a couple of words about what you can do. This really is a public health crisis at the national level. So this is a series of maps from the New York Times of the country dating back from 1999 on the top left-hand corner all the way down through 2015 on the bottom right. Every county is assigned a color there, with areas in blue representing low numbers of overdose deaths, and areas in red representing high numbers of overdose deaths. And really, as you can see, as the years have gone on, just how much of the country has been consumed by this crisis. These maps end in 2015, and things only got worse in 2016 and 2017. In 2017 in the US, 72,000 people died from drug overdoses. That is more in 1 year in the United States than the number of US soldiers that died in all 20 years of the Vietnam War. The president has declared a public health emergency around the opioid crisis, as have the governors of several states, including Governor Wolf here in Pennsylvania. And that is particularly appropriate given how bad things are locally. So these are now local data. These are from our medical examiner's office. And what they show are the number of deaths per year, dating from 2003 all the way through 2017. The number of drug overdoses is in red, and the number of homicides is in blue. And as you can see that back in 2017, there were 1,217 people who died from drug overdoses in Philadelphia alone. That's up from 907 deaths the year before, and roughly 4 times the number of homicides. This truly is a staggering number of people who are dying from drug overdoses in Philadelphia, 90% of which involve an opioid. here's a bit more about those individuals who did die in Philadelphia in 2017. On your left are the demographics of the overdose decedents. Predominantly non-Hispanic white males, ages 25 to 54. And as you can see from this graph, really no demographic group has been unaffected. And then your map on the right is of Philadelphia, and every one of those points is the location of someone who died of a drug overdose in 2017. So as you can see, we certainly do have this hotspot in Kensington. We also have areas that we're concerned about, clusters in West Philadelphia and South Philadelphia. But really what this map really shows is that no corner of our city has been spared either. If you look at the far, far end of the east, all the way down to the southwest part of the city, deaths are occurring everywhere. And it's important that we maybe put this into context of how is Philadelphia doing compared to other large cities in the country. And unfortunately, we are leading the pack. This graph shows the overdose death rate among the counties with the top 10 largest cities in the country. It's from 2017, these are 2017 data. And you can see our overdose death rate of 65 deaths per 100,000 residents far exceeds those of other large cities in the country. Chicago, New York City, Dallas, Houston, Los Angeles. So things really are particularly challenging here in Philadelphia. So how did we get here? How did we, unfortunately, claim this spot? So I'm going to talk about some of the local drug-related factors that have contributed to this, and then talk about some city-level factors as well that really coalesced to really drive our crisis forward faster than a lot of other cities in the U.S. But before I do, I want to pause for a second. I'm going to show a lot more data and a lot more statistics on the forthcoming slides, but I do want to pause for a second and ask that we all remember that those 1,217 people who died in 2017 from drug overdoses were 1,217 people. Mothers, fathers, brothers, sisters, friends, colleagues. And I encourage us all to remember that because we all know someone who has been affected by this crisis, and we wouldn't want them to be a statistic. For me, this is really personal as well. As much as I do think about this as a policy advisor in the health department or as a clinician over at the VA, this is very personal for me too. 3 years ago, I heard that one of my middle school classmates had died suddenly. And this is what was written in his obituary. He bore these multiple medical challenges with courage, without complaint, and with determination to live a normal life. In the treatment of his medical conditions, he was prescribed, became dependent on, and then addicted to pain medication and opiates. He was diligent in working his rehabilitation program and enjoyed a significant period of recovery that brought him happiness, connection with others, and greater self-worth. I expect this may resonate with a lot of you. Too many. How did we get here? Has any illness so penetrated American conscience and the fabric of our society as deeply as the opioid crisis? You know, I keep asking this, really, what brought us to this point? Well, the story really begins with prescription opioids. You may know these by their brand names such as Vicodin, Percocet, OxyContin, but what's important to know about these medications is that they're chemically similar to heroin, which was marketed in the late 1800s as a non-addictive alternative to morphine. It's kind of ironic. And because they're chemically similar to heroin, they're addictive, and they can cause an overdose. Despite knowing that, these medications have been prescribed across the country by medical providers to too many people, too high of doses, for too long. A lot of that was driven by very deceptive and aggressive marketing techniques by pharmaceutical manufacturers of opioids. You may be reading a lot about this in the newspaper these days around the Sackler family and Purdue Pharmaceuticals, the makers of OxyContin. And the campaign they really waged to get doctors to prescribe more of these medications. Unfortunately, that campaign was very effective. Sales of prescription opioids rose quickly. So this graph is from the CDC. These are, again, national data. But it shows 3 parallel lines dating back from 1999 to 2010. This green line here represents the sale of prescription opioids. The purple line below it is the deaths due to opioid-related overdoses. And the orange bar, or orange line at the bottom represents treatment admissions for opioid use disorder. And because it doesn't really make sense that deaths or treatment would drive sales, we really kind of conclude that it's sales that are contributing to this rise, this parallel rise in deaths and treatment. We've unfortunately seen that same trend in Philadelphia. So now we're back to the Philadelphia data. These are from the DEA. And they show trends in opioid sales from 2001 through 2017. You can see that our sales more than doubled from 2001 to 2012. They have come down since then, amid so much more recognition around the risks of prescription opioids. But they still remain far higher than they were back in the early 2000s. And if you imagine tracing this back where they were in the 1990s. Here's another way of thinking about it. The amount of opioids that are being prescribed in Philadelphia. These are now counties in the mid-Atlantic. And you can see different shades from yellow to light green to dark blue. Areas that are lighter color are lower rates of prescribing. Whereas areas with darker blue are much more intensive, much higher rates of prescribing. There we are in the middle, Philadelphia, in a pretty dark shade of blue. It's interesting because that's pretty significant variation from what you see in DC, Baltimore, and then up in New York. So much so that in 2015, enough opioids were prescribed in Philadelphia for every person to have nearly 1 full month of OxyContin. And we care about the length of a prescription because it is directly related to the likelihood someone might be on it for long term. This was a study that was done by the CDC. It was a very interesting study, I thought. That took a group of opioid-naive individuals, people who had not had an opioid before. And they looked at how many days was their first opioid prescription, and they charted that against what was the likelihood of them still being on it 1 year and 3 years later. So if your first prescription for an opioid was 5 days, you had between a 5 and 10% chance of still being on those opioids a year later. But if your first prescription was for 30 days, not an uncommon amount, you had between a 30 and 35% chance of still being on those a year later. Now, there were limitations to this study. And people acknowledged that there are appropriate medical indications for prescription opioids. You hear about them used for pain related to cancer, for end-of-life care, hospice care. And people have said, well, maybe that's where all of these opioids are going. I'm going to make the case that some opioids are being used for those purposes appropriately, but that a lot of opioids are simply being overprescribed when they may not necessarily need to be. Here were a couple of studies that show that, but a lot more data has borne this out as well. But one study was of 79 dental patients. This was done over at Penn, and the researchers followed up with people who had a tooth extracted. 3 weeks after their procedure, 54% of those pills were unused. The next study in the middle of 212 dermatologic patients, the researchers followed up with them after they had undergone dermatologic surgery and found that 86% had pills left over and 35% didn't use any. And then finally, that last study on the right there of 1,400 orthopedic patients was done over at Rothman, over at Jefferson. And they followed up with individuals who had had upper extremity surgery. And what they found is that 66% of pills were unused. So there's a lot of opioid prescribing that is happening. And it can end up in medicine cabinets, unused, and then people might experiment with an opioid painkiller that they find. Because use can lead to misuse, which can lead to dependence and addiction. And maintaining addiction to prescription painkillers can be expensive. As a result, some people do make this transition to heroin. It's cheaper, and it can result in a more immediate high or a rush. So on your left are two pills of 30 milligrams of roxicodone, the street price of which in Philadelphia is about $25. And then contrast that with 30 milligrams of South American heroin, costs about $14. I think it's important to note that not everyone who misuses prescription opioids goes on to make this transition. But those who do are still 19 times more likely to make this jump from prescription painkillers to heroin. And that poses a particularly grave problem here in Philadelphia, where our heroin is particularly pure and cheap. So this graph shows a couple of different things, but let's focus on the blue columns right now and the left-hand y-axis, which is purity. And as you can see, back in 2015, this is from the DEA, Philadelphia had the purest heroin in the country, with samples averaging about 75% pure. And if you now look at the red columns and the right-hand y-axis, which is the cost, you see that we also had the cheapest heroin that same year. So you've got a lot of opioid prescribing that's happening, and you've got readily availability of heroin. So again, these were a little bit older data. These are from 2015. And unfortunately, our purity is actually going down in Philadelphia, but for the most sinister and unfortunate way, is that it is being made less pure by the presence of an even stronger and more potent opioid called fentanyl. Fentanyl is a synthetic opioid painkiller, so it's made in the lab. It's very potent. It's 50 to 100 times stronger than morphine. And that's sort of what this picture on the right illustrates, is that heroin is in that left vial. These vials are about 2 inches tall. And contrast that with a similarly lethal amount in an opioid-naive person of fentanyl. You get a sense of how dangerous this medication is. It's increasingly shipped from overseas to the US, and it can be added to heroin and to other street drugs, often unknowingly to the person who is using it. So even small amounts of this can cause an overdose and can kill someone who is an experienced opioid user. And that's sort of what this graph here is showing. This is again going back to local data. These are now the number of deaths due to individual opioids. And you can see back in 2010, our predominant opioid that was present in overdose deaths was this green line, pharmaceutical opioids. As time has gone on, we're seeing the evolution that I described here, being overtaken by heroin. So for several years, heroin was the most predominant opioid causing deaths in Philadelphia. And then really in 2016, seeing that sharp spike in orange, the presence of fentanyl. Fentanyl is what is killing most people who die from drug overdoses in Philadelphia today. So these are a lot of the drug-related factors that I've gone over now that have contributed to our crisis locally. But as you all know, as public health students and professionals, the environment itself has great influence on illness and public health burden. So I'm not going to spend a lot of time on these factors, but they are absolutely worth mentioning because this crisis is not occurring in vacuum. Harvard, we're the poorest large city in the country, with some 400,000 individuals living below the poverty line. And as we know, that poverty isn't equally distributed across the city. It's concentrated in certain neighborhoods, and poverty has exacerbated the opioid crisis. Homelessness, an issue facing many urban settings across the country. Philadelphia is certainly seeing its share of unsheltered individuals. Numbers are actually rising in the last couple of years. Adverse childhood experiences, or ACEs, trauma. A study done a couple of years or so ago showed that there were a lot of Philadelphian adults had experienced one or more ACEs. And ACEs are associated with substance use. And then finally, stigma. Stigma is not unique to Philadelphia, but is a reality faced by a lot of individuals in our city with substance use disorders. And I'm going to talk more about stigma later on in my presentation. But stigma is a social determinant of health. In the context of the opioid crisis, it is absolutely contributing to people's safety, their well-being, their willingness to seek treatment, and even how they're treated when they get there. I think it's important to point out that these factors that I've mentioned here are not necessarily causing. They are not necessarily causing drug use. But I bring them up because they're present. And they certainly complicate our efforts to address the opioid crisis. So this isn't all about drugs. But it's really thinking about the context and the environment in which drug use occurs. These are all happening across the city, but they are really colliding in a very public and glaring way, in addition to our drug-related factors in Kensington. This is an article you may have seen in the fall. It was published in the New York Times Magazine, describing the plight of Kensington and for the people who are trapped by the Walmart of heroin. This was honestly a very disappointing and troubling article to read. It does illustrate the plight of Kensington, but it does so in a very glorified way, objectifying those who are interviewed and really portraying in the most grim way possible what is happening in Kensington. It didn't touch on some of the great work that is happening on the ground there by some very dedicated and very committed organizations. It did a disservice, many feel like. But that said, things are challenging in Kensington. There isn't a way to sugarcoat that. It is a very difficult situation. All of those local drug-related factors that I spoke about, as well as the Philadelphia factors, have really conspired to create this perfect storm in the Kensington community. So much so that the city has acknowledged that our systems have been overwhelmed and that what we've been doing hasn't worked. And that was sort of what prompted Mayor Kenney to declare Kensington a disaster area, which he did late last year. So now that I've painted this very sort of challenging and bleak picture, what are we doing? And especially in response to thinking about the mayor's declaration of the challenge that exists in Kensington. I'll speak a few minutes about the Philadelphia Resilience Project, which is the Kensington-based efforts of the city to address the opioid crisis and its downstream consequences. And then move on to sort of thinking about really what is the health department doing to address the opioid-related factors that we face every day here. But here's a little bit more about the executive order that Mayor Kenney issued, declaring Kensington a disaster area, but then also what he wanted to do about it. So this is the preamble. It talks about the whereases and explains. The first one talks about drug overdoses, how we really are leading the way. The second one talks about unsheltered individuals and homelessness in Kensington and Fairhill. The third whereas talks about the new rise of HIV that we are now seeing, that I'll come back to in a few more slides. And the fourth whereas talks about some of the other effects in the community. It mentions that these encampments are places where drugs are bought, sold, and injected openly. Streets, schoolyards, and public places are littered with trash, human waste, and used syringes. This is, again, a very challenging situation for which there are no easy answers, and there is no silver bullet. But one thing that the mayor and his administration really wanted to do was to really reorganize how city services, at least, are organized. We're a big city, we're complicated, and we need to think about how do we improve our communication? How do we better align our efforts, our resources, to really have a tangible impact in Kensington? So that's what this statement says, that he is designating the Office of Emergency Management to run the Emergency Operations Center, or the EOC, to really think about how can the city do something new and better than what it was doing before. The result of that has been the Philadelphia Resilience Project, mobilizing 35 city departments to combat Philadelphia's opioid epidemic. This has really brought a lot of resources to Kensington, thinking about addressing homelessness, thinking about getting people into treatment, thinking about reducing fatal overdoses and the spread of HIV and hepatitis C. Talks about community concerns, talks about litter, talks about discarded syringes that have ended up on the ground here. I'm not going to get into the details of the Philadelphia Resilience Project, but if you are interested, here is the URL, and I will be happy to make these slides certainly available after this presentation to anyone who is interested in it. But I will move on now a little more to folks going back towards those drug-related factors, thinking about what are the interventions that the health department, or our partners, whether those are treatment programs, insurance companies, or community-based organizations, can do to help address this crisis. There are three general ways that we as a health department have thought about combating the opioid crisis. The first of which is to reduce the supply of prescription opioids to prevent people from becoming addicted in the first place. But we know there are already tens of thousands of people who are already addicted and need treatment, so we want to try to get them into treatment. And the third is to really acknowledge that not everyone's ready to enter treatment. We want to keep them alive so that if and when they are ready, they have a chance to. And so that's through the distribution of naloxone, a life-saving antidote to opioid-related overdoses. How we enact these three strategies was really the work of the Mayor's Task Force to come up with sort of the concrete blueprint that the city would use to address opioids locally. The task force worked from January through April of 2017. It was made of 23 individuals from all different agencies and organizations across the city. That's what that sort of white box in the middle there represents. It was co-chaired by the commissioners of public health and behavioral health. So it really solicited input and expertise from law enforcement, the jail system, EMS, the community, people with lived experiences, insurers, and the treatment system. Their work was informed by the 5 subcommittees that you see here. Public education and practice, substance use treatment, law enforcement and the criminal justice system, overdose prevention and harm reduction, and then really data sharing and analysis to understand what we're doing making a difference. I do want to just quickly say that among those 3 strategies that I mentioned that were sort of the public health ones, I didn't mention anything around law enforcement. I will say that there is certainly a component of law enforcement as a strategy to address the opioid crisis. I won't spend time on that today as it's not my area of work or expertise, but I would be remiss if I didn't also acknowledge the effort that our colleagues in law enforcement are doing, especially to disrupt the large shipments that are coming into the city. The Mayor's Task Force issued 18 recommendations for what the city and its partners could do to address this crisis that were broken up into these categories. Again, I won't go through all of those, but all 18 are available at our website here. I will touch upon just a couple that I think are sort of more relevant ones for what the health department, what my department has been doing to address this. One is to really improve healthcare professional education, recognizing that healthcare providers have played a role in this crisis. That may have been a lot of the influence of pharma companies who encourage doctors to prescribe more of these. But it still behooves us to now take responsibility for that and do what we can to help address them. So we mailed prescribing guidelines to 16,000 prescribing providers in the greater Philadelphia area. We conducted a public health detailing campaign to promote judicious opioid prescribing that ran from the end of November through early 2018, called Think NSAIDs, or encouraging people to think of non-opioid pain treatments called NSAIDs, or ibuprofen and Motrin. And a public health detailing campaign is when individuals from the health department were going into doctors' offices to provide one-on-one education around this important issue. That is the exact same model used by pharmaceutical companies to great effect. This has been shown to be effective in public health as well. Detailing efforts are not just around opioids, but also around tobacco and diabetes management, so it is an effective approach to changing physician behavior. And then we are working with the city's health systems on reducing the overprescribing of opioids and benzodiazepines. I have not spoken about benzodiazepines here, but it's a class of medications that's often used for sedation or for anxiety, and can really increase overdose risk, especially when taken with an opioid. We're working to increase treatment. So recommendation 6 from the Mayor's Task Force was to increase the provision of medication treatment. Opioid use disorder is a medical condition, not a moral thing. And there are effective treatments for it. One of which is this medication called buprenorphine, also known by its brand name of Suboxone. Other medications used for opioid use disorder are methadone, you may be more familiar with that one, or Vivitrol, which is extended-release naltrexone. What we've been doing as a city is to try to increase the number of healthcare providers who can prescribe buprenorphine, and then really having them develop buprenorphine induction protocols for classes. This seems like a very low-hanging fruit a natural way that we should be trying to address the opioid crisis by increasing treatment. And that is true from the philosophy of wanting to do more to help people who are already addicted. There are some unfortunate, though, regulations to this medication. You may be wondering, why are we even calling this out if there is this treatment that exists? Buprenorphine is a unique medication where you actually need additional training to prescribe this medication. I can prescribe all the opioids that I want. I can prescribe all the fentanyl that I want. And yet I need an additional 8 hours of training to prescribe this medication, which is safer and it is the treatment for opioid addiction. Nurse practitioners or physician's assistants need 24 additional hours in order to prescribe this life-saving medication. It's one of those really sort of challenging regulatory issues that exists at the federal level that is prohibiting us from really making a bigger dent in the opioid crisis locally and nationally. We're really working to increase naloxone availability. I mentioned this a few minutes ago. Naloxone is the opioid, it's the antidote to opioid-related overdoses. It's very easy to administer. It's a spray up the nose, much in the same way that you may use Flonase or Afrin. It's available to everyone in Pennsylvania due to a statewide standing order or a universal prescription. So you don't need your own prescription to go into your pharmacy to get naloxone. Just go in there and ask for naloxone, and you should be able to get it. But we've made an effort to even be more aggressive with getting this medication out there. And so since the middle of 2017, with our city partners, we developed a citywide distribution strategy, distributed over 70,000 doses of this medication, the picture of which is on the right, and trained over 2,000 people in overdose recognition and naloxone use. The last of the recommendations that I'm just going to spend a few minutes talking about is involvement in the criminal justice system, and recommendation 18, which was to provide substance use disorder assessment and treatment in the Philadelphia Department of Prisons. I call this out because some of the most innovative and meaningful work that is happening in opioids in Philadelphia is happening in our jail system. And that really is due to the leadership of Commissioner Carney and Bruce Herdman, who is the Chief of Medical Operations over there. So since the Mayor's Task Force, some of these things were already ongoing, but they've really made this much more of a robust process. They're providing substance use disorder assessment of all inmates on intake, CBT for addictions. Previously, if you came into the jail system and if you came in on methadone or buprenorphine, you were continued on it. But if you didn't come in on treatment, you weren't offered it. This wasn't a chance for you to get started on treatment. That changed in the early part of 2018 when the jail did a pilot offering buprenorphine to the women's facility. That proved to be successful. They subsequently expanded the program to all the men's facilities. And there has been a lot of uptake in this program. For some individuals, this may be their first time to actually get onto this medication in a stable way. There have been some hiccups, and we'll certainly not say that this has been the smoothest process. This has been a big lift for the jail system, but it is a big step forward. The jail system is providing overdose education of inmates and visitors, and is distributing naloxone directly to individuals at the highest risk of an overdose. So not just telling them to go to their pharmacy and get the medication, but actually giving them the medication itself. One of it wasn't a formal recommendation, but one of the other takeaways from the Mayor's Task Force is that we need to develop an opioid program in the health department that would do surveillance, monitoring the effectiveness of our interventions, and then also really produce more of a much more user-friendly portal for the public to really engage. So I share this now, the URL is at the bottom, and I do want to call your attention specifically to the right, the Reports and Data tab. We reorganized the data so that it really is much more user-friendly and hopefully engaging for you as students and researchers. So please check that out. Please be in touch with us if there are issues or challenges or questions that you have about the data. Because we do really want to make sure that this is as available to everyone who is interested in it. So I'm going to move on now a little bit and talk about some of the things that have evolved in the last year. I've given a presentation and talked about opioids in different settings, but really, when I was doing that, I was thinking about all that's changed in the last year, things that have come up, new challenges and opportunities, and spend some time talking about these. These are some of the more dynamic and changing things right now that are happening in Philadelphia. and really call those out as ways to really for you to think about and to engage. Talk a little about the crack epidemic, talk about the resurgence of HIV, talk about new threats. I'll mention something about overdose prevention services. You may have heard about these as supervised injection sites or supervised consumption spaces. And then talk about some of the policy opportunities and political realities that we are facing in the health department, and that's my role as a policy advisor. But I do want to pause for a minute and talk about the crack epidemic. A lot has been made about this crisis being called a crisis, and people caring because the opioid crisis is affecting white people. And that no one cared, certainly not with compassion, during the crack epidemic of the 1980s and 1990s, when a lot of black and brown individuals were dying of drugs. So there's two things I want to say about this. The first of which is there's absolutely some truth. There were a lot of misguided, wrong, racist policies that disproportionately affected black and brown communities, especially here in Philadelphia. I think we need to acknowledge that. We need to admit that those were wrongs. But we also need to learn from them now too and not repeat the same mistakes we made before. We couldn't arrest our way out then, we cannot arrest our way out now. The second point I want to make is that the opioid crisis, our current crisis, is not just a white problem. In Philadelphia, in 2017, in all racial and ethnic groups, more people died from drug overdoses than they did from homicides. In fact, the greatest rate of increase that we saw was among Hispanics. And so this was a quote that was published in an opinion piece just 2 or 3 days or so ago in the New York Times, and I think is worth sharing with you here today. Labeling the opioid crisis as white risks overlooking the very real damage experienced by Black, Latino, and Native American communities. This is not a call to ignore the wrongs of the past. We should continue to scrutinize how attitudes towards drug users seems to change depending on the racial identity of the people whose story the media tells. But this crisis is a reminder that anyone can become addicted to drugs. Our empathy should not be conditional. The next challenge that I want to share is a bit about the resurgence of HIV that we are now seeing amidst this opioid crisis that we are having. These are data from the health department, our AIDS activities coordinating office. These are the number of new cases among people who inject drugs by quarter, going back to the middle or third quarter of 2015. And as you can see, there has been a noticeable increase, a significant increase in the number of new HIV cases among people who inject drugs. This is absolutely alarming. We have this perfect storm in these conditions for a major outbreak of HIV, hepatitis C. And I say that it's particularly alarming because we have made so much progress. One of the most significant, most important public health interventions in addressing the HIV crisis of the early 90s was the implementation and development of syringe exchange, offering sterile syringes and sterile drug paraphernalia to people who were going to inject. So this graph shows the impact of that intervention. This graph is the number of new cases of HIV per year among people who inject drugs. You see this significant increase from 1983 all the way up to 1992, such that in 1992 there were 819 new cases of HIV in Philadelphia alone among people who inject drugs. That was when our syringe exchange program opened. It was Prevention Point in Philadelphia, it's up in Kensington. And since then we have seen this remarkable decrease in HIV among people who inject drugs. That is stunning. That is a real public health achievement. In 2016, there were 27 new cases of HIV among people who inject drugs, which represented just 5% of the new cases seen in Philadelphia that year. But the opioid crisis is testing our syringe exchange program like never before. Compared to heroin, fentanyl has a much shorter duration of action. It comes on very quickly, but then it also wanes very quickly as well. So that people who were used to injecting heroin 3, 4, maybe 5 times a day, now they're injecting heroin fentanyl by itself, 8, 9, 10 times a day. So ensuring that for all of those injections they have access to sterile syringes is a huge challenge. That's so much more resources than Prevention Point has been giving out before. And yet we want them to. We want them to keep giving out as many syringes as possible to prevent the likelihood that they're going to run out of a sterile syringe, maybe need to share a syringe, and thereby put themselves at risk for HIV or hepatitis C. So we're encouraging that. But now we're running up against a new tension that exists in the community that has been greatly affected now by the discarding of all of these syringes that are being given out. That's a very real concern. You hear about it from community members who are anxious. They see so many syringes on the street that they have to then pass on their way to work, their kids have to pass on their way to school, or are ending up in the parks in which their kids play. So there is this tension that's existing now around what do we do about this, about syringes. We don't want to pull back, given the fear of concern for spread of HIV and hepatitis C, but we also need to acknowledge the concerns and the challenges facing our communities. One way we've worked to address this is through the installation of these needle drop boxes that you see on the right. These are large boxes in public spaces. They look like mailboxes. They're available all the time, and you can just discard syringes in one of these boxes. There are seven of them right now. They exist up and down Kensington Avenue at the SEPTA stations, as well as one outside of McPherson Square, which is the one that's seen in that picture there. These have been an important intervention. They have not been a silver bullet. We recognize that, but they have, in the months since they've been installed, collected thousands of these discarded syringes. So sort of one way that we've tried to reduce a public health burden experienced by the community while balancing it with our need to keep getting syringes into the community, especially among those who are using drugs. And then there are new threats. This crisis is ever evolving, which is part of the excitement and the fun and the challenge of being in this space. But it's also really hard. And here are some of the issues that we are now grappling with. Lethal fentanyl and cocaine intoxication. As I mentioned before, fentanyl is making its way into all sorts of drugs. It was making its way into heroin. It is now pretty much almost universally in our heroin supply as well. And in some ways, that's not okay. But from a risk reduction point of view, these individuals who are knowingly injecting heroin know what an opioid overdose looks like. They may have naloxone on their person, or they may be using with someone who has naloxone. Fentanyl is now showing up in cocaine. This poses a totally new problem because individuals who are using cocaine may not think that they're at risk for an opioid-related overdose. They may not know what it looks like or what to do if an opioid-related overdose occurs. Unfortunately, increasingly, we are seeing fentanyl found in combination with cocaine. So this was a research letter that was published in the New England Journal by our colleagues over at the University of Pennsylvania following an outbreak that we had last summer, where there was a cluster of people who were affected by this and some who died thinking they were using cocaine solely and no thought of using fentanyl, no thought they were using fentanyl. So now we need to be aware of the fact that fentanyl is in everything and think about how do we actually now engage populations who we may not have had to before. Our messaging is different. The population is different. So we're thinking through what are the ways that we strategically can engage populations and make sure they're aware that fentanyl is in everything. They may be at risk even if they don't want to be. And so make sure they know what it might look like and to have naloxone on them. And then you have synthetic cannabinoids. This picture is from Twitter. It's from Barry Logan, who is the director of a forensic laboratory just outside of Philadelphia. And basically what he's pointing out are these packets of heroin labeled Santa Muerte that contain this new synthetic cannabinoid, 5-FADB, nothing that rolls off the tongue, but something that was found in our heroin supply. There have been a lot of anecdotes about fentanyl making its way into synthetic cannabinoids, which you may know as K2 or spice. Fentanyl making its way into that drug, so that people who thought they were smoking K2 ended up smoking fentanyl and having an overdose. But this was the first time that we were aware of K2 making its way into heroin and fentanyl, and people actually injecting this drug. Synthetic cannabinoids are generally not injected. So this was a new challenge that we were faced with, and over 150 people ended up in REDs in 1 weekend. So these are some of the new threats that we're grappling with. There's new drugs coming onto the scene, such as synthetic, novel psychoactive substances, such as K2 and synthetic cannabinoids, and then also existing ones being found in new combinations, as we saw with fentanyl and cocaine. I'm going to shift gears a little bit here and now talk a little bit about overdose prevention services. It's a bit more of a controversial public health intervention that you may have heard about. Overdose prevention services have been shown to reduce the harmful effects of drug use. So overdose prevention services, again, also sort of known by its name of a supervised injection facility or a supervised consumption site, are places where people can bring pre-obtained drugs, use under medical supervision, such that if an overdose occurs, there is medical staff there available to help them, to reverse an overdose, to call 911. It creates a safe space where someone can use their drugs that they have brought in under supervision. There are more than 100 of these around the world. They've been very effective. Millions of injections have occurred in these facilities. Thousands of overdoses have occurred in these facilities. No fatal overdoses have ever occurred in one of these facilities. There are none operating in the United States above ground, per se. There are 2 sites that are underground that are being part of a research protocol that are occurring in the United States. But really, there's a lot of effort to think of this is what is needed to help address our opioid crisis in the country. So a lot of cities are looking at these. And they're doing so because there is so much data, there are so much data in support of them. These facilities over years, the most well-known and well-studied one is in Vancouver. These have been shown to save lives. They reduce HIV, hepatitis C, and skin infections. They reduce public drug use and discarded syringes. And they help get people into treatment. They provide a space for people to get to know them, develop that rapport, much like our syringe exchange program does, so that when the person is ready, he or she can enter treatment. They do so without increasing crime around these facilities. These are a controversial initiative, so there are a lot of cities that are considering this. None has opened one of these in the United States. Philadelphia is one of those cities that is moving forward towards opening one of these. Early in 2018, the city, the health department, the administration came out in support of having one or more of these in Philadelphia, believing that they could help address our opioid crisis. Again, they're not a silver bullet. I'm not going to pretend that this is going to reduce our fatal overdoses down to 0 by any means. But this really could make a difference. What the city acknowledged during that time, too, is that we would support a nonprofit to run one of these. So this is the Inquirer article that announced that this new nonprofit had been formed. It's called Safe House. It's being, 2 of the board members are here. Some of you may know these folks. On the left is Rhonda Goldfein, who's the executive director of the AIDS Law Project. And on the right is Jose Benitez, the executive director of Prevention Point Philadelphia. They and their nonprofit, Safe House, have been working to open one of these in Philadelphia. This is their website, so if you're interested in learning more, their URL is at the bottom. I want to mention here this quote from the American Medical Association, which does acknowledge this is an important public health intervention. Now I'm going to move on in 1 second, but I will just acknowledge that where this is at now, again, all of this sounds promising, as a way of addressing the opioid crisis. But there has been some concern voiced by the Department of Justice that says that one of these should not be allowed to open, and one of these is illegal in the United States. So a suit was brought by the U.S. Attorney for the Southeastern District of Pennsylvania, and this is now being discussed and will be heard in a federal court. What happens here will probably have implications for what could happen across the country. So all these other cities are moving forward with this idea as well. San Francisco, Seattle, New York City, Denver, Ithaca, and Philadelphia are some of the ones that have been more vocal and more public about their support of one of these. That's sort of where this stands right now. I'm going to now move into sort of the policy space here a little bit, and this part of my presentation about policies. Because as much as an overdose prevention site could help save a lot of people, our data unfortunately also show that 75% of the people who died from a drug overdose died in their own homes. And having such a supervised consumption space may not have been able to help them. So for that reason, we are trying to get more and more people to carry naloxone. If you know someone, a friend, a family member, a roommate, who may be at risk of an overdose, we want to make sure you have naloxone. Again, it's available to everyone via a standing order in their pharmacies, except for the problem that not all pharmacies carry the medication. This was something that was illustrated to us, again, by a study from Penn, from the fellowship program over there, that found that over 40% of pharmacies, only 40% of pharmacies had naloxone in stock. There was geographic variation in the percent of pharmacies that carried it. And it's important to note that the 19134 zip code, Kensington, were the least likely to have this medication available in pharmacies. So following this study, the health department partnered with pharmacy schools across the city and really did more of an intentional education outreach to pharmacists. So please carry this medication. It's really important that people have access to this. It can be filled by anyone under a standing order. Please consider carrying this. That intervention increased the number of pharmacies that were carrying it up to about 75% of pharmacies as of last year. And that still meant there were over 100 pharmacies in the city that were not carrying this medication regularly. So one policy opportunity that we saw was to support this idea of making this a requirement and just having pharmacies carry this medication. So that was a bill that was introduced and passed by council last year. There was, we had the support of local pharmacies and certainly the city council to have this, so that pharmacies are now required to stock at least 2 prescriptions worth of naloxone. And they're all required to post the sign that's on the right there. The naloxone is available. So hopefully in the next couple of months, you will now begin to see this in your pharmacies because it should be available. I mentioned a second ago that we had support from local pharmacies. And I mentioned that because it contrasts with this next policy opportunity that I'm going to talk about, for which there was significant political pushback and barriers. And that brings us sort of almost full circle and coming back to the role of pharmaceutical reps. And how can we avert the next drug crisis? By putting some parameters around what pharma reps can do here in Philadelphia. As much as we want to think about the opioid crisis, we need to still think about ahead. What may be coming next? And yet there is still a lot of marketing that's happening to doctors about opioids. This is what this study shows. This is an abstract from the study. And the authors looked at industry payments to physicians for opioids. And basically what they found was that 1 in 12 doctors received a payment involving an opioid between 2013 and 2015. Right in the middle of this crisis, 1 in 12 doctors accepted a payment from an opioid manufacturer. That payment could have been in the form of a gift, could have been in the form of a free trip somewhere, or it could have been in the form of a meal. In fact, 94% of all of these payments were about food and beverage. And there's a reason for that, because meals influence prescribing. That's what this graph shows here. This is one of the most neatly dose-responsive in a research study, right? So on the x-axis is the number of meals received by opioid manufacturers in 2014, and then the y-axis here is the number of opioid prescriptions written by those number of doctors in 2015, a year later. So with each meal that you receive from an opioid manufacturer, the more likely you are to prescribe opioids. there is a reason that pharma invests far more in marketing to doctors than they do on research and development. This is the influence. And it's not just about opioids. Opioids are the most glaring example of this, but it isn't just about opioids. Vioxx, one example of this, is a non-steroidal or a non-opioid pain medication that was became one of the manufacturer's best sellers. Unfortunately, it was also associated with an untold number of heart attacks and strokes. And it turns out that the company that made this knew that and told their sales reps to downplay those risks when making sales calls. Really trying to push this medication. Risperdal is another medication that has had sort of this unfortunate story of being marketed for off-label purposes. Risperdal is an antipsychotic medication, and it turns out that the manufacturers were promoting this for doctors to prescribe to elderly patients when there wasn't an FDA indication to do so. There was a False Claims Act brought by the US government, and that was ultimately settled. The last medication that I'll just mention here is Paxil, an antidepressant medication, which paradoxically increases the risk of suicidal thought among teenagers and adolescents. Again, it turns out that the manufacturers of this knew that before they started promoting this medication for use among teenagers and adolescents, trying to push this medication to be sold through gifts and through all of those sorts of things. That now has a black box warning advising that we do not prescribe this to that population. And then it really is the rise of prescription sequence that most concerns us now. These are data from Philadelphia. And you see this very sharp rise in prescribing of amphetamine or Adderall, and then this rise in Vyvanse, which is the newer stimulant medication. And then also sort of this ongoing prescribing of methylphenidate, also known as Ritalin. And you imagine that this pales in comparison right now on an absolute level to how much opioids are being prescribed. But this is probably how the opioid crisis began. It had to start somewhere, and seeing this rise over a couple of years in the amount that it was being pitched. So I'm running out of time here, so I'm just going to end with a couple of things here. So this policy opportunity that I mentioned, we were trying to put some common sense parameters on pharma reps here in Philadelphia. One of which would be to ask them to register with the health department, to provide us with their materials used for marketing. Not that we approve them, just so we have a sense of what's being marketed. Ask them to not give out coupons for, discount coupons for controlled substances, and prohibit the use of gifts. You could visit doctors as much as you want, just don't give a gift. Don't bring a meal. Do all the education that you want. That was a bill that was introduced by council members Greenlee and Bass late last year. It was reintroduced earlier this year, and unfortunately failed. There was a lot of pushback from the industry as well as its allies. The Convention Bureau, which felt that pharma companies were going to take their business elsewhere and deprive the city of billions of dollars. The restaurant industry threatened that they would have to let their frontline staff off because they depended so much on these pharma meals. And then the medical society opposed this as well, saying that this was getting in the way of patient care, it was taking away physician autonomy. And afterwards, this was the editorial that the Inquirer wrote in response to the vote. The Inquirer had been very supportive of this. The no votes for the pharma bill represent a vote for the culture of quid pro quo, which is bad enough, but it's infinitely more deplorable as the city struggles to stem the devastation of death and destruction caused by opioids. 9 members of council just turned their backs on this crisis. They owe every family that has lost a loved one an explanation as to why. So I think I am now out of time, so I'm just going to mention these last 4 things here then. What you can do. I feel like I've just now given you sort of this tour of things that are challenging, but also I want to end with some things that you can do, because you absolutely can do some of these things. Be informed and share about the risks of drug use. You all know so much more than so many of your peers. Please just have some of these conversations. It's important that we just get more and more people thinking about this and talking about this openly. Support drug take-back programs. Reducing stigma and then getting trained in naloxone. Support drug take-back programs. It's just the idea of getting rid of those medications that may be in your medicine cabinet. The DEA sponsors 2 national take-back days. They collect about 36,000 pounds in Pennsylvania. There's a picture of Governor Wolf at the Walgreens on Broad and Chestnut. And as you can see behind him, here's one of these medication disposal bins. You can just take your medicines there, no questions asked. It's not just controlled substances, so any medication you may have, you want to get rid of, please use one of those. They are in selected pharmacies and police departments. police departments not being the ideal place for these, but really to think about that more locations are needed. Reducing stigma by changing dialogue. I'm sorry I am accelerating here. I apologize for that. But I really want to just mention this. This is an article that came out in the Inquirer 2 years or so ago, almost to the day, called The Hidden Hellscape. It was about the encampment that was below that was on the railroad tracks at Gurney Street. But what stood out was just the very liberal use of the word addict. It kept saying it over and over and over in the article. Really jarring work for a lot of people who read this article. And I say that because we really should be thinking about people, not labels. So in medical school, I was always reminded, you don't call someone with asthma an asthmatic, or a person with diabetes a diabetic. That's defining them by their illness. And yet somehow we have found it okay to call people addicts or schizophrenics. And I encourage you all just to be aware of the language that you use and that you hear, because it can shape the way we all perceive this issue. Whereas addicts perpetuate stigma, personalization is not. This was a quote from Zachary Siegel, an individual in recovery himself. Being an addict defines my humanity with one small facet of my identity, essentially erasing the rest. And we as healthcare providers and professionals are not immune to this as well. There is a lot of stigma that exists in the healthcare field as well that we need to be honest about as well and address. And this is a study that shows that. This study is from 2010. When a hypothetical patient was described as a substance abuser, healthcare providers were much more likely to find the patient culpable and recommend punishment. If the patient had a substance use disorder, they were more likely to recommend therapy. So the language that we use really does matter, and I encourage you to think about that. This is a quote from the former drug star, Michael Botticelli. The language we use to describe the disease can either perpetuate or overcome the stereotypes, prejudice, and lack of empathy that keep people from getting the treatment they need. Our previous Surgeon General said that compassion is what allows us to stop judging and start helping. We need local communities to become sources of compassion and understanding. We need to do that by sharing not just the stories of heartbreak, but also the stories of hope and recovery. So this is my penultimate slide here, I do promise. Is a plea to please get involved and get trained in carrying naloxone if you aren't already. Again, you can use Pennsylvania standing order to get it. Obtain it from pharmacies. Again, all pharmacies in Philadelphia are required to carry this. If they are not, please let us know. If you're interested in training, they are available. The health department, the Department of Behavioral Health, our community organization partners, all offer free monthly trainings. And we can walk you through sort of what it looks like to carry naloxone. And I really do encourage you all to please consider doing that. You may be in a position to save a life. And really, every life is worth saving. Thank you.
Thank you very much for an excellent presentation. You've given us so much to think about and to do. Unfortunately, we don't have time for questions because we hit our time limit, but perhaps we'll stick around for a few minutes if others would like to just come up and ask questions. Thanks.
I'm happy to stick around, and then my email is on here if you'd like to be in touch. Thank you.